Welcome to the fourth installment of the IEL Collective Conversation. We've had a really good reception to our first three videos looking at the relationship between international economic law and COVID-19. I mean, these are a series of videos that we are doing as a collective, and hopefully we'll be branching out into non-COVID areas in the future, but at the moment this is very much focused on the pandemic. We at the IEL Collective have been looking at the relationship of international economic law and law in generally, and the intersections between law and health epidemics. And we are very, very happy today to have this conversation with two global health experts. I am Celine Tan. I am a reader in law at the University of Warwick, and my research centers on the intersections between international economic law and development, with a particular focus on development finance. And I'm very pleased to have with us Sharifah Sekalala from Warwick and John Harrington from Cardiff, and I'm going to ask them to introduce themselves very briefly. Sharifah?
Hi, my name is Sharifah Sekalala, and I'm an associate professor at the University of Warwick. I work primarily on global health law, and I'm interested in the nature of making global health law, in financing, and increasingly, I'm also thinking about how states use global health law in order to respond to infectious diseases. John and I have been working on an article on human rights and global health law within humanitarian health crisis, and thinking about how state obligations for human rights within this crisis. So it will be good to kind of think about some of these and other thoughts within this conversation.
I'm John Harrington. I'm Professor of Global Health Law at Cardiff University and co-director of the Centre for Law and Global Justice at Cardiff. My work is particularly focused at the moment on the nation state and global health law and governance, and how the nation state is reconfigured or transformed or resist global health governance, the role of nationalism, which has been coming to fore. And I've been lucky to be doing the work with Sharifah that she's just mentioned as well.
Brilliant, thank you very much both. So one of the things that we have been discussing within our video conversations is really looking at how law has been deeply implicated in the constitution of the global and local economies, and the relationships, the intersections between what we would traditionally call international economic law, investment, trade, finance, with other areas of international law like global health governance. Again, breaking down those traditional boundaries that we find, in our discipline. And really just looking also and discussing how, law, particularly international economic law as well, been really deeply implicated in creating the conditions, right? The social economic conditions that give rise for this kind of spread of pandemics today. And also really just illustrates how, and exacerbating really how the kind of social economic dislocations that kind of accompany these kinds of epidemics. And we've seen that actually in regional epidemics with Ebola, with SARS, with the avian flu. This is kind of what we would call, I think, the truly global pandemic in many senses, and quite unprecedented. So what I would like to ask both of you really is that, international economic law is not quite familiar or au fait with, sort of the global health frameworks, and the World Health Organization, WHO, is becoming so prominent, but very few people outside sort of global health communities actually understand what the nature of the WHO, international health regulations. I wondered if we could give us a little bit of an insight, a bit of a summary before we go on to kind of the more substantive discussions that we'll have today. Sharifah?
So the World Health Organization is an organization that is composed of almost all member states, and its primary duty is to ensure that states have that states attain the highest duty of physical and mental health for their citizens. It's quite a democratic organization. It has regional offices in all the continents. So there's like an African regional office, a European one, and so forth. And it makes its decisions through the World Health Assembly every year, in which all member states kind of get to have a say about decision making. John, do you want to talk about the IHR?
Yes, Sharifah. So the international health regulations have their origins in the 19th century. Interestingly, Celine, in the balance between trade and public health, and originally addressed the restrictions that states could put on the traffic of people and goods at their frontiers in order to limit the spread of disease while not disproportionately burdening trade. And its origins is in a kind of inter-imperial deal between the British, French, and other empires. The international health regulations had a list of diseases, named diseases, which gave rise to further action on the part of states as a requirement. They were seen as out of date as new emerging diseases came up, things like SARS and avian flu. And so the IHR were revised in 2005, and they're the ones we have in force now. And the IHR tells states in more detail about the measures that they can put in. Importantly, the current IHR allow non-state bodies to communicate with the WHO to give them information about outbreaks, so it widens it out in that sense. It extends beyond the list of named diseases. It makes mention for the first time of human rights, and it talks about the requirements of states to keep a strong capacity for detecting outbreaks, for notifying the WHO, and lastly, it commits states to support each other in building this capacity. And the last thing, the work that Sharifah and I have done most recently, that paper suggests that that's a weak obligation. States aren't really committing a lot of funds, and we may be seeing the consequences at the moment.
Thank you, John and Sharifah. So I just wanted to pick up on that issue of the IHR and state obligations. So, I mean, there are various sort of news items now, commentaries about the fact that they weren't obvious in this particular pandemic. They really didn't work. They weren't effective in terms of placing, you know, those obligations on states to notify, particularly China, when apparently, you know, there was an outbreak and the WHO didn't take action at that point. Now, to me, it seems, as somebody who's not an expert in this area, it seems that you know, the WHO has been functioning as within its remit, and so the question goes to whether you know, the WHO acted, you know, within the constraints that it had, within, you know, the structures that it had in the international health regulations, and in that sense, then the question moves on to the other question would be, you know, do we need a reform of those, and are there other mechanisms of international law that we, you know, that you know, we can use in order to, again, you know, move things and mitigate health epidemics, the COVID, you know, funding, etc.
So I think you raise a really important point about the WHO's actions at the beginning of the crisis. So what happens is that when an institution, in this case China, reported the early signs that there was an epidemic, the WHO as an institution has a process. So it's not the Director General who arbitrarily makes up his mind. There is a process which has experts who sit down and determine whether this is what ideally we call a public health emergency of international concern. So this committee met, I think, 2 times before, and I think the earliest indications was that it wasn't sufficient. They thought that it might be contained regionally, and so it did not declare this public health emergency of international concern. Subsequently, then declared a public health emergency of international concern in January. And then you then have certain procedures about reporting the number of cases, which I think China largely complied with. So there are all sorts of issues around the timeliness of that. But I think one of the things to consider is that in some ways the WHO can't win. So either it declares emergencies too quickly or too late. So in the DRC, which was the emergency before that, there were questions that it had declared it arbitrarily when the cases that had crossed borders were too few. In Zika, it was criticized because it declared it, and actually then that managed to be contained in the DRC because it was too late. And I think it's really a hard situation. So we have a fine balance of having the experts give these expert opinions, and then the Director General takes this advice on the basis of expert opinion, as opposed to having arbitrary decisions in terms of what becomes a public health emergency or not. Sorry, I was wondering whether John wanted to add anything to the decision making.
I don't have a lot, anything much to add on that specific point. The wider political context has, particularly, let's contrast the SARS outbreak in 2003 with the current outbreak. SARS also emerged, admittedly, in southern China. And that saw an outflanking of the Chinese state by, on the one hand, its own scientists, and on the other hand, the World Health Organization. The Chinese state wouldn't notify the WHO for quite a considerable amount of time and shut up shop against an effective response. So the scientists notified the WHO unofficially, and the WHO made statements about travel advisories and so on. And China was forced to comply, to adapt its response. In this case, the intervening almost 20 years have seen China rise in importance, not just economically, but also in terms of global governance and international institutions. And a French colleague was saying earlier this week that the staffing and funding of the WHO has been increasingly influenced by China, increasing Chinese commitment at all levels. And so we've seen a much closer working, I think, between Geneva and Beijing on this outbreak. The claim, as you've seen from Trump today, is that the WHO is dominated by China. I don't think that's true, but that it has greater influence is certainly clear in this case.
So I just wanted to pick up on that point, John, and also going back to your earlier point about the history or of the international health regulations. You know, its role in sort of actually, you know, was fundamentally about economics, right? It was about, you know, how far health, you know, is going to affect, you know, the cross-border trade, et cetera, et cetera. So, I mean, I think a lot of I mean, certainly from a pedestrian understanding, a lot of this also feeds into the existing kind of economic trade wars that are happening between, you know, the China and the United States. But beyond that, what I would be interested to kind of like talk about a little bit, really, is in terms of where do you see, in terms of global health governance, despite, you know, the problems within the WHO, it's actually quite invigorating. It's something that we talked about, Luis Zislava, Tara Van Ho and I talked about in episode 2 of the video conversations about how multilateral institutions that are much more democratic, as you mentioned, Sharifah, and much more diverse, much more constituted by expertise, right? So, you know, that are perhaps, you know, the way to go in terms of not only containing health epidemics, but also in relation to the global economy, because we have institutions that are coming in now, like the World Bank, like the IMF, giving funding to countries. And so, but these institutions, the governance are problematic because it is very much dominated by certain countries. And I wonder how, I just wanted to get your views on how you see the WHO working alongside the other multilateral institutions, or have you given much thought in terms of the financing even, because there's a lot of financing coming from the World Bank, and the WHO has traditionally been very much starved from, you know, like funding, or at least, you know, part of the problems that led to these, you know, interventions, global health interventions, is the lack of funds for the WHO.
So I think before we go to funding, I think something interesting is happening within this space. So as you kind of correctly stated, a few months ago, most people hadn't heard of the WHO or the international health regulations. And something interesting is happening in this space where things that, regulations that people thought were on the fringe of their existence have become central to states, but also individuals' existence. So we think much more globally about the spread of disease. And I think that that's going to be a really interesting thing going forward when we start thinking about multilateralism, because it's becoming much more relevant to people's everyday experiences. The second thing that I think is becoming interesting is to think about what we want organizations to do, but also their constitutive structure. So a lot of these multilateral institutions have fairly weak constitutive structures in order to harness everybody and bring them together. But that also causes problems then if you kind of want to think about obligations of states to act. And you mentioned financing, the fact that states can shrug off their financing obligations, the fact that states can shrug off their obligations even to the IHR in terms of reporting, in terms of continuous assessment of systems, because what I find interesting is that at the moment we are very much focused on the IHR and thinking about reporting obligations, but lots of things that we are seeing in country about the weaknesses of health systems are identified in the IHR as things that countries need to do in order to deal with an epidemic. So these are obligations that countries have signed up to, that if there is an epidemic, you can cope. You have a system that has clearly already identified, for instance, who your essential workers are, that has identified how your supply chains will work within the crisis. And I think that it's the revisiting of this space about what regulation means, both to the individual, but centering the multilateral, that nobody can do it alone. We're in this together. John, do you have anything to add to that?
I'll add a bit of history, Ken, to all that. And it might be of interest to international economic lawyers and law and development people. The WHO has a number of phases in its history. It's founded after the Second World War as part of the range of UN bodies which are founded or reconstituted then. Its initial incarnation is really a very medical, doctor-focused, technical, gives technical advice, and doesn't push out into health policy until the 1970s. When, in consonance with the new international economic order movement, it embraces health for all strategy. And the famous Alma Ata Declaration, which it organizes with UNICEF, is very much a global south-centered, near-areaist type approach, to also informed by the China of the day, the barefoot doctors, traditional medicine. And like those initiatives, that hits a wall in the early 80s for reasons we know, structural adjustment, debt, and so on. And institutions, particularly the World Bank, move into the space that the radical WHO had been occupying, and effectively push a more targeted, donor-supported approach to health. user fees and limitations, which create some of the problems we're talking about. The most recent phase, which Sharifah has been writing about, has seen an expansion again of global health governance and global health concern, but done around the WHO, particularly by philanthropies like Gates and Bloomberg, or ad hoc bodies like the Global Fund on AIDS, Tuberculosis and Malaria, or the Vaccine Initiative. And I guess to come back to Sharifah's point about the present is perhaps the COVID-19 pandemic is an opportunity, looks like being an opportunity, to pull the WHO back into the middle, to do it properly on a multilateral and comprehensive basis.
And so that really leads us great into our other point that we want to talk about, which is the obligations of states, right? So this is building on the paper that you guys are working on right now, which is on the extraterritorial obligations, human rights obligations of northern states. So, you know, I think we can talk about multilateralism, but at the end of the day, as you rightly pointed out, John, I mean, the conditions that gave rise to the possibilities of a pandemic like this, and also the social economic dislocations that are coming and will come with great force on the aftermath of this pandemic, is being created by, you know, the legacy of colonialism, of structural adjustment, of interventions by the northern states into the south. In many different permutations, right? So in that sense, also when we talk about financing, we talk about aid, and this is something, again, we've been kind of reiterating over the course of the collective conversation, something that gets raised constantly. It's about these issues about redistribution and reparations. And so that kind of leads in a way into that kind of, when we're talking about extraterritorial obligations and the obligations on states that have greater resources to then, you know, ameliorate, mitigate, repair this situation. So I just wanted, you know, to kind of have that discussion with the both of you on this.
Yeah, so I think states' responses have been really interesting. So at the moment, most states have been really inward looking. So as a group of us have been thinking about emergency laws and how these emergency laws are really inward looking. They are protecting each individual nation state at the expense of somebody outside it. So for instance, you have the UK ban the exportation of essential medicines. The EU is banning the export of essential supplies. The United States is banning the export of personal protective equipment. And we also still have sanctions against some countries like Iran, which make it really difficult to deal with a crisis if you have sanctions against countries. And I think that there are existing obligations already in various international treaties, starting with the UN Declaration on Human Rights that kind of speaks about this duty to assist. We have them in the International Covenant on Economic, Social, and Cultural Rights, which deals with the right to health. And also kind of the IHR under Article 44 has just realized that countries cannot deal with this alone. And I think that that's really essential because you cannot, infectious diseases mean that we are all equally vulnerable, and we are as vulnerable as the weakest link. And I think COVID-19 neatly illustrates this, that no matter how amazing your health system is, no matter how good your doctors are, if you do not deal with the countries that have these weak health systems, then we have a problem. And that's where kind of this duty, the extraterritorial duty to assist, becomes really important. And that is one of the reasons why the IHR under Article 44 looks at it, because it thinks you cannot deal with this in isolation of systems in other places.
Yeah, I think there are some of the things that we are looking at. There are these obligations scattered around not just general international law, but around international health law. The problem is twofold: enforcement is weak or non-existent. And relatedly, the definition is also not as clear as it needs to be. So the Article 44 of the IHR that Sharifah mentioned, it reads like an exhortation to states, be nice to each other. It's almost like a humanitarian injunction. And that needs to have more bite at a time like this. The obligations in the International Covenant on Economic, Social and Cultural Rights have been developed in the General Comments, General Comment 3, General Comment 14, and given quite a bit of more precision. And the Committee on Economic, Social and Cultural Rights issued a statement on COVID-19 on Monday, addressing some of the issues that Sharifah was talking about there. And I think there are two types of issues here that have come up in exercises like the Maastricht principles on extraterritorial human rights obligations, which would be very useful to us. On the one hand, there's the obligation, imminent at least in international law, and in some places explicit, to cooperate and provide assistance. And a robust approach to that will look at it widely. It will look at historic issues. The second strand for the Maastricht group was cases where states actually cause harm to other states. And they developed this quite a lot in their commentary about where the state actively does it through sanctions, like Sharifah mentioned, through military action, impinging on health, as we see here, but also the state as host or regulator for corporations, for example. And we see this happening with Trump's America buying up protective equipment on the tarmac at Shanghai airport so that other countries, and I mean, that's simply France, which is bad, but clearly there's even less chance of it getting to Malawi or Paraguay or wherever. Cases where states cause harm through acts or omissions are something that we need to think about here. Patent laws. This was a big, and still is a big issue in relation to HIV/AIDS. Should we go back to this as an issue? Should we re-examine the patent system? Is it needed at all in this case? Questions like compulsory license. These are all international economic law questions, and health lawyers have been dealing with them for the last 20 years, but they're crystallized at this point, I think.
Yeah, that's really something to think about. Again, we've not talked about human rights obligations here very much. We've talked a lot about inequality as well, and that's I think what this demonstrates as well. In a health pandemic, it looks like the wealthy are getting being able to stop planes on the tarmac, use that financial also military might to be able to source that. The equipment, but also that leads us quite neatly onto the other topic that we wanted to talk about, which is this inequality, and it's something that we talked about in our episode 3 with Serena and Paolo on the different ways in which this pandemic is being manifested. And I think this also relates a lot to extraterritorial obligations of states. It also relates to financing, the duty to finance, to fund. So in a sense, I see this as the two parts of this. One is what you so eloquently put, Sharifah, in terms of the fact that we are as vulnerable as the weakest link in the system. So we need to fund. So global security is everybody's security. There's that self-interest there. But also the second part of it is also about the inequality. If we created the conditions for inequality, and if we can see now, the impact of it, because in the United States and in the UK, I think there's now data coming out to show that populations in the Black ethnic minority groups are most disproportionately affected in terms of fatalities from COVID and others. And also, I think on BBC News, which I haven't watched, they talked, again, there was a whole program dedicated to looking at inequality. So I think health inequalities is an indicator of the social economic inequality within states. And that again is underpinned by the social economic model that we have, which is again underpinned by law, right? Because the law constitutes for these systems. So I just wanted to bring our discussion into that arena and talk a little bit about these inequalities.
Yeah, so in the work that John and I did, we deal a lot with the idea that human rights are interlinked and you cannot deal with one right at the expense of others. And I think that government measures for social distancing are a really good example of this. So some people are going to find it really difficult to social distance because they don't have adequate housing. You are going to have that people in slums cannot really adequately social distance, even if they wanted, because there is just no space. Space is at such a premium that it's just going to be impossible. And when you think about kind of the fact that I think it's 31 million people globally who live in slums, that is a huge part of the population who will just find it really impossible. But you see that even in the most developed countries, so people who live in places where they do not have gardens, they do not have adequate access to public spaces. And so you're seeing these inequalities manifest themselves and make it very difficult for governments to effectively contain a pandemic. And this is something that human rights scholars have been talking about for a long time, that you need to deal with gender, you need to deal with education, you need to deal with housing, and all of these are economic, social, and cultural rights. And unfortunately, we haven't prioritized them as much as we ought to have. We've really focused on civil and political rights, like the right to free speech, or the right to life. But I think that you realize that people actually are dying if you do not sort these things out. And I think that that's really problematic. And you're also finding that these inequalities are appearing even in places where you did not kind of expect them. So you raise a really good one of the data is showing that if you're poor, you're just more likely to die. But I think that also it's equally showing us that actually we need to take care of everybody, because it's in some ways health is does not discriminate. So health outcomes do not discriminate because people will die. But it's also in the government responses. The government responses are prioritizing the commercial against the social, even in ways that kind of just do not make sense. So if you look at the economic stimulus packages in North America, in Europe, a lot of them are really to protect corporations and not to make people's lives better during the crisis. And I think that that's deeply concerning, but also deeply problematic in terms of dealing with a public health crisis. And I think John had some other really key insights about it.
So I'd add to what Sharifah said by drawing attention to interesting work on global health in international relations, which talks about different framings of global health problems and interventions. And we've talked about two of them already in a way. We've talked about trade and the economy as a frame. We've talked about human rights as one with potential, but it's unrealized. But the other frame, which is persistent and strong, is the security frame, which presents the threat, as Sharifah has said, as a threat to the nation and to the state, to its boundaries, to its healthy population, to its economy conceived of as a national thing. And the things that Sharifah has mentioned about national procurement and supply lines and so on, all represented in national terms. This isn't always negative. We're talking about the National Health Service in the United Kingdom, which has its limits, but is a mobilizing force. On the other hand, we've seen the negative or difficult sides of this, particularly with Trump's utterances and some of the practices of wealthier states. And clearly security resonates in the global south in conditions of inequality between states of military imbalance between North and South. The fact that, for example, many health facilities in East Africa, for example, are funded and run by the United States. The Centers for Disease Control, which is a part of the US military, has its origins in the colonization of the Philippines. It does excellent work, but it's also related in that way. And US Army medical facilities are a very large part of the delivery of healthcare and pandemic preparedness in the global South. So it's useful, I think, to see it in with reference to those friends.
Thanks, John. I think it really is. It brings back this notion of also the relationship between civil political rights as well and economic, social, cultural rights, which Sharifah mentioned. Because one of the things that, a statement I saw quite early on in the pandemic response from a former minister in Liberia was something along the lines of, sometimes, you know, the kind of violent acts, the kind of security mobilization of the state in the global South are often the only means that the South has in containing this. And he was, I think, referring to the fact that you were seeing these scenes of where police officers were trying to contain mass gatherings and using force to disperse gatherings. And a lot of this, you know, it was, you know, it couched in a way of state violence, but actually it's because maybe the state doesn't have any other options in order to contain that epidemic, but to use that because, you know, you've got weak capacity in terms of, you know, public health systems, or there are not enough civil, you know, public health officers to go round. You've got the slum issue of lots of people packed into the same road. You haven't got public transportation that works. Majority of people rely on public transportation, so they can't disperse, you know. So I just wanted to kind of talk a little bit about that kind of responses and how, in a way, what can we do? And it links back to the finance issue, right? It links back to, you know, whether you think that the current package deals that are going out, we've touched a little bit on this, fiscal stimulus packages have been oriented to interest, I guess, you know, that are not looking at, you know, how we actually resolve things on the ground in terms of mitigating, you know, so the immediate thoughts of mitigating the pandemic, but also broader, wider issues about, you know, how do you build state capacity to respond to this? How do you then, you know, deal with the economic fallouts that will happen as a result of this? So I just wanted to kind of like, you know, move us into the direction of solutions probably in the kind of last part of our conversation, to see what you think on a multilateral and also on a local level, what, you know, we can do, what you see, what you recommend states and policymakers to do at the international and local level in order to kind of get a grip on this situation.
Thanks, Celine. So I think in some ways it's linked to your question. So I think for a long time, global health has suffered with short-termism, and Liberia is a good example. So in Liberia, you built lots of emergency hospitals for Ebola, and you closed them before anybody ever stayed in those emergency hospitals. And these were built with donor money at the height of the crisis. And so in some ways, we really need to radically rethink global health law for the long term and stop thinking about crisis after crisis, to stop thinking about that lens of security that John refers to. Because the problem is, if you think about a security lens, then you think about each individual security threat as something that you must deal with, and you're not thinking systemically. And I think this gives us an opportunity to radically rethink global health, to radically rethink organizations such as the WHO that did this kind of thinking with states and had benchmarks about states in terms of immunization, in terms of maternal health. And now we've dissipated these to different institutions. So each organization is looking at its own series of indicators. And if we are very lucky, then the WHO amalgamates that information. And that is really problematic for the long term. And we also need to then fund it seriously and sustainably. And I think we have good opportunities to do so in terms of sustainable long-term funding within the multilateral structure that we have, but we're not really doing this very seriously. We are always responding. So if you think about pandemic bonds, for instance, they are really short-term solution to what is really a structural long-term problem. So if you had a pandemic bond for COVID-19, it would not solve a structural problem of housing or homelessness. And what's really interesting is that at the end of the 2010, kind of at the end of we were starting to think about this with AIDS. We were starting to think we really can't deal with this short-termism anymore. We need to think about structures, and we seem to have lost that. So once something ceases to be a big-term threat, we lose that sense of structure changes. And I think that that's exactly what we need in global health right now.
I'd certainly agree with all of that. Structural transformation, to a certain extent, a return to the kind of things that were being planned and done in the 1970s. The new international economic order, the broad view of health, a focus on grassroots issues, not exclusively. You can't reject pharmaceuticals. They're an important part of the strategy, but I'll quote Sharifah back to herself. Yesterday, she said, if you supplied clean running water to everyone, most of the health burden, a great deal of it, would be reduced. And it's important to remember, we had a briefing from colleagues working in Southern and Eastern Africa, a health network. More people are still dying at the moment of malaria, of HIV/AIDS, of diarrhea while this is going on. The numbers are terrible on COVID, but it's happening in the north. It's hitting the core areas of the economic and political system. It's getting attention, that's right, but it's not the only one out there. So the breadth of approach that Sharif is talking about, returning to some of the traditions and public health practices, human rights can give us quite a bit here. Article 12, the right to health in the International Covenant of Economic, Social and Cultural Rights, is interpreted as an inclusive right, which draws in obligations on structural factors, the underlying determinants of health, things like water, education, civil and political rights for women, for example, which are health promoting for themselves and for others. And I suppose I would add to Sharifah's point, a focus on the nation state, particularly in the global south. You've both mentioned these coercive interventions. Kenya, which is a country I've worked in and I'm working on, we've seen really terrible violence exercised by the police and paramilitary police against ordinary citizens by way of enforcing curfews and lockdowns. And it's important, I think, to think the southern state in its complexity, and perhaps to accept that there are parts of the southern state, I know, and Sharifah knows, there are ministries of health, ministries of child welfare, national research institutions, which are fully oriented to a rational public health strategy. There are other parts of the state, like the police, like the ruling party, like the lifelong president or whoever, who are entrenched in a coercive, violent, more or less irrational routine, a repertoire which they draw on in this situation, which comes down from colonial times, but which has been amply refreshed in the now half century of independence. And in some ways, the multilateral effort that Sharif is talking about needs to be complemented or realized by an energized mobilization of those parts of southern states, indigenous parts, if you like, which have the best interests of the people at heart, if I can put it like that.
That's a really good note to end on, John. And I think also learning, seeing the state in the South in all its complexity, but also in all its positive aspects. I mean, you see states, some developing states like Malaysia, for example, which have taken a very, organized, rigorous, approach to dealing with this. And there's also infrastructures to deal with infectious diseases within the tropics that are, common across a lot of developing countries in East Africa, in Southeast Asia, in South Asia. There are institutions that work and are working, and those are the voices that we're not hearing. And I think this goes back to your issue earlier, John, about framing. So it's been a pleasure to talk to the both of you and discuss all these great issues. And I want to just give you one sentence wrap up or anything that you wanted to say at the end, and in a way galvanizing us to moving the community and forward in looking at possible solutions, and also reframing what we understand in the relationship between sort of global health and the economy. So I'll just give you the opportunity to have a chance to have two, liner end.
So my take from this is that global health law matters. Global health lawyers occupy this strange space for most of the time, kind of trying to shop for relevance. And when push comes to shove and there is a crisis, it matters. We have to go back to the law, and we make national laws that take into account the global, and so we need to take it seriously.
Yeah, I'd agree with that. I think law has potential here. We've talked about human rights. We all know the limitations of human rights. But I think this is a good time to work on them and to push on them. And a phrase I came across in Tanzania when I was researching Julius Nyerere's strategy, grassroots strategy, was mtu ni afya, the person is health. A grassroots, citizen-focused approach can't be dispensed with.
Thank you very much, Sharifah and John. And details of Sharifah and John's contacts, Twitter would be in the captions somewhere in this when one of our colleagues does her whiz-bang tech stuff. Follow us on our YouTube channel for more IEL Collective conversations, and hopefully you'll hear more from Sharifah and John as things progress on different issues, maybe not particularly relating to COVID, but other aspects of global health. Thank you all very much. Subscribe to our YouTube channel. Check us out on the IEL Collective Twitter account. Keep us posted and all the marketing things that I have to say. Thank you all. Thank you.